respiratory distress syndrome is life-threatening. This disease does not allow our patient to effectively ventilate and oxygenate on their own. This is a medical emergency. We need to act now.
ARDS causes the lungs to change from clear to consolidated, with fluid building up in the alveoli. This makes the lungs heavy, stiff, and difficult to expand for a breath. ARDS can be caused by many major direct or indirect injuries to the lung and can affect nearly 10 to 15% of all ICU or intensive care unit patients and 20% of all patients on the mechanical ventilator. This includes aspiration of vomitous or foreign material, inhaling noxious chemicals, especially from cigarette smoking, lung transplants, pneumonia, septic shock, and various types of trauma, either internal or external to the lung field. When we suspect a patient may have developed ARDS, we perform a quick bedside assessment. As practitioners, we may also receive orders to analyze an arterial blood gas. Other healthcare professionals will draw blood for labs, culture urine samples or sputum samples for possible infections. A radiologist may perform a bedside chest X-ray to help determine where the greatest damage in the lungs is located, and an EKG technician may perform an electrocardiogram to help doctors rule out heart failure on an X-ray. Finally, a pulmonologist may perform a bronchoscopy to observe the actual bronchioles inside the patient. Symptom onset is usually within 24 to 48 hours, as patients decline so rapidly that they cannot explain of their discomfort. These symptoms can include difficulty breathing, low blood pressure and organ failure, rapid breathing, shortness of breath, bilateral infiltrates on chest X-rays with pulmonary edema, and a PF ratio of less than 200 regardless of PEEP or peak and expiratory pressures. Treatment options include first, immediate admission to an ICU with the goal of supportive ventilation and a doctor's order for prone positioning. Traditional therapeutic goals remain mechanical ventilation to address refractory hypoxemia and provide additional medications to provide possible infection control, reduce inflammation, and remove excessive fluid from the lungs. Patients often need to be deeply sedated, especially with the atypical mechanical ventilatory settings designed to protect their lungs. These ARDS-NET protocols that respiratory therapists employ are designed to give the patient smaller volumes at faster breathing rates due to limited and restrictive lung expansion. This protocol also addresses how to oxygenate the patient with cautious stepwise increases in FiO2 and PEEP to maintain an oxygen saturation between 92 and 98%. Some hypercapnia may also be permitted as low tidal volumes raise the PaCO2. Lung damage is a very real concern for these patients as the ventilator does not automatically change its settings based on the patient's lung compliance. This may mean that too big of volumes or pressures for too long can cause volutrauma or barotrauma respectively. Also, patients on the ventilator are at an increased risk for developing ventilator or hospital-acquired pneumonia or pneumothorax.
We must be vigilant in the care that we provide as we expand our knowledge and treatment options in managing this disease process.